Assalamu alaikum everyone, my name is Osama Khamaj and today I'm going to be explaining electrophysiology and excitation-contraction coupling of the cardiac muscle. Those are the first two lectures of CVP block. Physiology lectures. Okay, so just a quick note, this is not a substitute for the lecture. We're just doing this in order for you to maybe understand it better. Maybe you didn't understand it well from the professor. So this is a chance for you, maybe it's a chance for you to revise. And let's get started. First of all, let's make some stuff clear. The ionic gradients, sodium and calcium are higher outside of the cell when we're talking about cardiac muscle and cardiac cells in general. Sodium and calcium are always high outside of the cell, so they want to move into the cell. Now potassium is higher inside the cell, so it wants to move out of the cell. And now if you notice right here, you have the equilibrium potential. Now sodium, when sodium moves into the cell, it wants the membrane potential to reach plus 60. It gets it closer to plus 60 millivolts. While potassium, when it moves out of the cell, it wants the membrane potential to be closer to minus 90. And the same thing for calcium. If calcium is moving into the cell, it wants the membrane potential to reach or get closer to plus 130 millivolts. So you can see here that it shows the difference between the nodal cell action potential and ventricular muscle fiber action potential. And if you notice, the resting potential of sinus node cells is minus 55 to minus 60, while the resting potential for ventricular muscle fibers is minus 85 to minus 90 millivolts. Now, why the difference? Sinus nodal fiber membrane is more leaky to sodium and calcium. Now, I told you that sodium and calcium want to push the membrane potential to more positive values. So here it makes it more negative. If you notice, since the membrane is more permeable to sodium and calcium, it pushes it to less negative values. So this allows the resting potential of this nodal cells to be less negative than that of the ventricular myocytes. Okay, why is there no stable resting potential in nodal cells? You notice that unlike ventricular muscle fibers, nodal cells don't have a constant resting potential. It's always moving up. And the reason for that is funny sodium channels. Funny sodium channels allow sodium to constantly move into the cell. And this allows it to reach threshold to generate an action potential. And this small part, the presence of funny sodium channels on nodal cells is the secret to the heart's automaticity. The heart is an automatic, it has it's automatic, so it never stops, it never rests, it's always beating. There's always an action potential being generated. That's why it's always going up, it's always trying to hit the threshold potential. And now, we want to explain the different phases in nodal cell action potential. Like I said, funny sodium channels are responsible for reaching the threshold potential, which is about minus 40 millivolts. And then for the depolarization, we have slow calcium channels. These are responsible for the depolarization of nodal cells. And then for repolarization, we have potassium channels. They allow the nodal cell to repolarize and go back to its resting potential, so it can generate a new action potential again. It never stops, remember. And now for cardiomyocytes. Now, if you notice, cardiac myocytes have very fast depolarizations. And what's responsible for this very fast depolarization are fast sodium channels. Unlike nodal cells, we have slow calcium channels. Okay, and then we have a plateau right here. Of course, there's basically no difference between Purkinje fibers and ventricular muscle. There's a slight difference, but you don't have to worry about that. Okay, so it has a plateau, if you notice, in cardiomyocyte action potential, specifically cardiac muscle. Okay, there's a plateau. What causes plateau? Like there's basically no change, no significant change in membrane potential. Slow calcium channels allows influx of calcium ions into the cell, while some potassium channels are open and they allow efflux of potassium. So calcium going in, potassium going out. It kind of cancels out, so there is no significant change in the action potential, and the membrane potential, which causes plateau. And then calcium channels close, potassium channels open, which causes repolarization, and the cycle goes on again. Okay, now there are two differences, major differences that you will notice in the action potential of skeletal muscle and cardiac muscle. And both of these differences are very significant to the function of cardiac muscle. Now, if you notice, the depolarization in cardiac muscle is much faster. It goes up really quickly than in skeletal muscle. Now, how does that happen? Because we have fast sodium channels in cardiac muscle, which allows for instant sodium influx. Sodium directly enters into the cell, while in skeletal muscle, it's slightly slower. Why do we want that? We want the heart to act as a functional syncytium. Syncytium is a very important word to understand. We want every single cell to depolarize and repolarize at the same time. Okay, so the heart can pump the blood more effectively. Now, another difference you might notice is the plateau that we talked about earlier. The plateau is present, first of all, slow calcium channels, they're open. And permeability of potassium is less in cardiac muscle. When we talk about cardiac muscle, potassium has less permeability in this during this plateau. And there are calcium channels, slow calcium channels. So, like I said, calcium going in, potassium going out, it kind of creates a balance, which creates this plateau. Why do we want this plateau? We want a longer contraction of the ventricles because we want to push all of the blood out of the heart. We want to push as much blood as we can, so we need longer contractions. That's why longer depolarization, so longer contractions. That's why I have this plateau right here. Okay. Now, to understand the electrophysiology of the heart, you have to understand the normal conduction pathway of the heart, the normal electric conduction pathway. So the SA node initiates the first action potential. Like I said, nodal cells do not need an impulse from outside of the heart. It creates its own impulses. So SA node impulse generates from the SA node. It moves through internodal pathways all the way to the AV node. The AV node, what it does is it delays the conduction. It delays the conduction for about 0.13 seconds, and then it allows it to move into the AV bundle. They get separated into the left and right bundle branches, and then impulse travels to the Purkinje fibers. They allow for fast, they penetrate the muscular wall, and they allow for fast impulse transmission. Okay, now the SA node, like I said, it's capable of self-excitation, does not need something from outside, does not need a signal from the brain to start generating action potentials. It's directly connected to the atrial muscle to allow for immediate atrial contraction. We need immediate atrial contraction we can push all of the blood into the ventricles. Now the AV node, its position is on the posterior wall of the right atrium. What it does, it basically delays the conduction, like I said, by 0.13 seconds before it reaches the contractile fibers of the ventricles right here. Okay, and of course there are three internodal pathways: the anterior, the posterior, and the middle, and they all converge into the AV node. And we have Purkinje fibers, of course. They carry the impulse all the way to the ventricular myocardium at very high velocities. Now, we didn't mention the interatrial pathway. The interatrial pathway connects the left atrium to the SA node. Why do we want that? Because we want the left and right atrium to contract at the same time for efficient ventricular filling. We want both of them to contract at the same time so we can fill the ventricles with blood. And like I said, we need the heart to work as a syncytium. We can't have one part contracting and the other not. We can't have the right part contracting and not the left. So, like I said, the AV node delays the conduction of the impulse. Now it takes 0.03 seconds for the impulse to travel from the SA node to the AV node. It stays for 0.09 seconds at the AV node, and it stays at the penetrating bundle of the AV node for 0.04 seconds. All of these add up to 0.16 seconds, so that's the total time it takes for the impulse to travel all the way from the SA node to the bundle branches right here. And this slower conduction, how does it happen? It's less gap junctions. Gap junctions allow for ion transfer between cells. If you have less gap junctions, you have slower ion transfer. Okay, so we said that the Purkinje fibers have carry the impulse at very high velocities, and the ends of these fibers, they penetrate about 1/3 into the muscle mass of the ventricles. They have high permeability of gap junctions. Like we said, here we have a very high velocity of impulse transmission, so we need high permeability of gas junctions, a lot of gap junctions. And then another property is that they may or may not contract during impulse transition. They don't always contract. And like I said, they carry the impulse at a very fast rate. This is very important to remember. Okay, they carry the impulse at 6 times the velocity of that of the ventricular muscle fibers. Okay, so these are the main arrival times. First of all, of course it's 0 seconds at the SA node because it is generated in the SA node. And it takes 0.03 seconds to arrive at the AV node. Like I said, there's a delay of 0.09 seconds between the AV node and the AV bundle. And this allows the ventricles to contract after the atrium contracts. Okay, and then it arrives at the ventricular septum 0.16 seconds after the impulse was generated in the SA. Now let's talk about sympathetic control of the heart. The heart is controlled by sympathetic fibers from T1 to T4. Okay, these nerves release norepinephrine onto beta-1 adrenergic receptors. What they do is they increase the permeability of sodium and calcium ions. Now let's go back to the thing we explained here. Okay, they increase the permeability of sodium and calcium. What does that do? It moves it towards the positive values of membrane potential. So that allows it to be closer to the threshold potential. It increases the excitability. You don't need that much higher uh, influx anymore. So this allows for a few changes. Okay, it results in increased rate of SA discharge. More impulses are being generated by the SA node. It increases the rate of conduction. It increases the velocity of conduction, and also it increases excitability in the myocardium. Like I said, this is also caused by sodium and calcium influx. Since the membrane is more permeable to sodium and calcium now, then it moves to the more positive values and becomes more excitable. And then we have parasympathetic control of the heart. The parasympathetic control, the vagus nerve controls this mechanism. It releases acetylcholine, which activate potassium channels in the SA node and AV node. Little note, it does not affect the cardiac muscle. It only affects the nodes in terms of parasympathetic control. Sympathetic control, however, if you notice the nerve fibers going all the way into the muscle wall, so it does affect the muscle wall in sympathetic control, but not in parasympathetic control. So what it does, it basically, like I said, we go back to the gradients, okay? It activates potassium channel. It allows it to move out of the cell. So what happens? It wants it to move towards the negative values. If it moves to the negative values, it's gonna be the resting potential will be lower, a bit lower, because it's gonna be more negative. So it's gonna be harder to reach the threshold for discharge. So what this results in? It results in less impulse generation from the SA node and less impulse transmission from the AV node. Okay, now these are the normal rates of discharge. Of course, they're not fixed. They can vary from a person to a person. For example, athletes, they usually have a lower rate of discharge, but this is like the average. SA node is 70 to 80 times per minute. AV node is 40 to 60 times per minute, and Purkinje fibers is 15 to 40 times per minute. Now let's talk about ectopic pacemakers. We know that the SA node is the main part of the heart which generates the impulses. Now, what's an ectopic pacemaker? It's when a region of the myocardium controls the action potential impulse instead of the SA node. Now, if any part in the heart controls the generation of action potentials, we call it a ectopic pacemaker. It can arise due to two different conditions. When there's a region of the myocardium, which is the muscle cells, they develop self-excitation impulses at a rate higher than that of the SA node. So, for example, we said that the SA node fires at a rate of about 70 to 80 times. If we have muscle cells that fire impulses at a rate higher than this rate, or higher than the rate of the SA node, then it will control the rhythm of the heart and it will produce self-excitation impulses. Okay, that's one case. The other case is when we have blockade of transmission through the AV node. Like we said, in normal transmission, SA node fires an impulse, AV node transmits it into the ventricles. If the AV node does not transmit it into the ventricles won't have an action potential reaching them. So what happens? Purkinje fibers take over. Purkinje fibers will be the ones to generate the action impulse for the ventricles specifically. Now the atria will still beat from the SA node, the action potential, but Purkinje fibers will will take over the ventricular contractions, and as you see, SA node has a much higher rate than the Purkinje fibers. So it will not be synchronized, the atrial and ventricular contractions. The atria will contract many more times than the ventricles. Okay, now in the case of AV blockage, the Purkinje fibers, like we said, they take over ventricular contractions, but they don't immediately take over. It takes 5 to 20 seconds usually for them to start generating self-excitation impulses. Now, during this 5 to 20 seconds, there won't be ventricular contraction, so there won't be blood being pushed to where one of the most important organs in our body, the brain. So what does this cause? It causes the person to faint, causes syncope, it's another word for fainting. And if this is prolonged, if this happens for a longer time, this can lead to death. And this is called Stokes-Adams syndrome. Okay? Now, moving on to the next lecture, a P2. We need to understand a very important property of the heart. It always acts as a functional syncytium, normally, not always. Normally, it acts as a functional syncytium. All the muscle fibers should depolarize and repolarize at the same time. They should contract together. And how do we have that? Intercalated discs. Intercalated discs are very important because we need gap junctions between the cells, the muscle fibers, the cardiac muscle fibers. We want it for rapid ion flow. We need rapid ion flow so all the ions can move and diffuse across the whole muscle. So the muscle contracts at once. And also another property of cardiac muscle is striations. Striations are due to the presence of actin and myosin. We won't go into the details, but because of the presence of actin and myosin, it's similar to skeletal muscle. Uh, we have striations. You can see those lines, those are striations, and these black lines are intercalated discs. Now, like we said, we have a plateau. Now, we're going to talk about a different aspect of the plateau. Before we talked about, we said that we need the plateau for longer contraction of the ventricles. Now, we want to talk more electrical. Okay? During the plateau, there is a period called the absolute refractory period. It lasts about 0.25 to 0.30 seconds. During this period, the muscle cannot be excited again at all. You cannot excite the muscle. Okay? Now, 0.25 to 0.3 is for the ventricles. Atrial refractory period is 0.15 seconds. It's a bit short. We have something called the relative refractory period. The relative refractory period is just after the plateau. It lasts about 0.05 seconds, and only some strong, really strong signals can excite the muscle, and this will lead to premature contraction. Now, I want to show you the premature contraction. Like I said, this is the refractory period. During this period, no action potential can be generated. Okay, this small area, 0.05 seconds, is where only some strong signals can generate a new action potential. And you can see it right here in the premature contraction. In the relative refractory period, a strong signal allowed a second action potential. It doesn't have the same magnitude as the normal action potential since it's premature, but you can see it. It's an early premature contraction. Now, this is a later premature contraction. It occurs towards the end of the relative refractory period, and it has similar magnitude to the normal action potential. Now, I need you to focus here. T-tubules. What are T-tubules? Now, in the membrane of cardiomyocytes, we have these invaginations. They're called T-tubules. What's the significance of T-tubules? It has a high concentration of calcium channels. Now, normally when the heart is relaxed, the cardiac muscles relaxed, you have extremely low levels of calcium in the cytoplasm. This is the cytoplasm. Everything white is a cytoplasm. This is outside of the cell. But everything here, everything you see here is a cytoplasm. We have very low calcium. Okay, but when calcium influx happens, there's something called calcium-induced calcium release. Calcium ions bind to these ryanodine receptors. They allow calcium to escape from the sarcoplasmic reticulum. Sarcoplasmic reticulum has a high concentration of calcium ions, unlike the cytoplasm. Cytoplasm has a very low concentration of calcium ions during rest. So, calcium ions that enter from outside of the cell, they activate these calcium channels which allow calcium to escape into the cytoplasm, and calcium of course binds to troponin C, and it causes contraction. Okay, so this is the important process of calcium-induced calcium release. It's a very simple process. T-tubules, what's the significance of T-tubules? They create little space. You know, there's little space. They make it closer to the sarcoplasmic reticulum. The channels they want the channels to be closer to the sarcoplasmic reticulum. Okay, now let's talk about tension. Okay, active tension is the force generated by cross-bridge formation by actin myosin. Okay, if you notice here, there is no active tension. There is no cross-bridge formation. The more cross-bridge formation you have, the more active tension you'll have. Look, it increases right at this point. At this point, you have the maximum cross-bridge formation. You can't have more cross-bridge formation than that. Okay? And then it starts decreasing. Here is where a lot of students start getting confused. Why does it start decreasing? Now, when the sarcomere shortens for at a length less than 2 micrometers, what happens is they overlap. The actin filaments overlap. What happens is there's disruption in the cross bridge formation. So you won't have as high active tension. Active tension will decrease. Okay? Passive tension is a different story. Passive tension is the force generated by the stretching of the myocardial wall. When the myocardial wall stretches, this creates passive tension. Now, I'll elaborate on that on the next slide. Okay? First of all, you have to understand the Frank-Starling law of the heart. In the Frank-Starling law of the heart, uh, first of all, the law is that the greater the stretch, the greater the force of ventricular contraction. Okay? How is this stretch achieved? Okay? We need to understand the end diastolic volume, the blood present in the ventricles after it is filled with blood, creates this stretch because we have titan, like we have titan right here. It's it's an it gives the heart, the ventricular walls, elasticity. So when you have more blood, it kind of gets bigger, the ventricles. It gets bigger and it stretches. Okay? If you can see this analogy on a slingshot, if you have if if you have a ball, you have a rock right here, okay? If you move it further back, you'll have a stronger, the ball will fly stronger. Okay, so same concept applies to the heart. If you have more end diastolic volume, you will have greater stretching, which will cause a stronger contraction. This is called preload. You preload the heart with end diastolic volume of blood, which creates a stretch, which allows the heart to contract, ventricles to contract stronger. Afterload is different. A lot of students can differentiate between preload and afterload. So for the left ventricle to eject blood into the aorta, into the rest of the body, the aortic valve has to be open. This valve right here. Now for it to be open, we need to have higher pressure in the ventricles than in the aorta. Okay? So the job of the left ventricle, the muscles in the left ventricle, is to contract and create pressure that's higher than the pressure that is present in the aorta. Okay? So afterload is basically the aortic pressure that needs to be overcame so we can push more blood into the aorta and we can open the aortic valve. Okay? So you can say that afterload is equal to the aortic pressure. Because we need to eject the blood into the aorta from the left ventricle. Okay, now we're going to explain the relationship between velocity of contraction and preload and afterload. The greater the preload, the greater the EDV, the greater the velocity of contraction. Okay, why is that? Because we have an increased stretch of the myocardial wall. This will cause faster recoil. Again, we go back to the same analogy. If we have greater stretch, we'll have faster ejection. You can see here, if you stretch it more, it will move faster. Okay. Now afterload is different. The greater the afterload, the lower the velocity of contraction. Why is that? Because we have greater opposing force from the aorta. We have high aortic pressure. If we have high aortic pressure, there is higher opposing force to overcome. So this will cause the velocity of contraction to be lower. Now imagine you're throwing this underwater. Would it move faster in water or in air? Of course in air. Why? Because there is less opposing force. Water has greater opposing force, so the rock will move much slower in water. And I'm done. Thank you guys. Good luck on your exams. Bye.